A better way to pay your UTG fees with instant proof of payment and real-time student portal update. Paying your University of the Gambia fees has never been easier or more convenient. With Ecobank, students, parents and guardians can pay UTG tuition and related fees through our secure digital banking channels such as Ecobank mobile app, Ecobank online and Ecobank Omni Lite. Once payment is completed, instant proof of payment is generated and the UTG student portal is updated in real time, allowing students to proceed immediately with registration, course selection, and clearance without unnecessary delays, while giving parents and guardians peace of mind that payments have been successfully processed. How to pay via the Ecobank mobile app. Open the Ecobank mobile app and navigate to the home screen. Select Pay Bill. Choose Pay a New Bill and select Schools from the category options. Select University of the Gambia. Select the specific product you are paying for. Enter your matriculation number and tap Continue. Validate your details. The system will display the payable amount. Press Continue to confirm the payment. An e-receipt is generated automatically as proof of payment with real-time updates on the student portal. How to pay via Ecobank Online or Omni Lite. Log in to Ecobank Online and Omni Lite using your credentials. Select the menu and choose Bill Payments. Choose Quick Bill Pay and select School from the category options. Select University of the Gambia. Select the specific product you are paying for. Enter your matriculation number and tap Continue. Validate your details. The system will display the payable amount. Press Continue to confirm the payment. An e-receipt is generated automatically as proof of payment with real-time updates on the student portal. Walk into any Ecobank branch or pay through our digital channels and enjoy instant proof of payment with real-time updates on the student portal. Ecobank, the Pan-African Bank.
Santa Yala.
Lekar, utul wave, nga scan, nga fay, nak doo ci yokku dara.
Jah Oil Company stands tall as a trusted name in energy, keeping the Gambia moving with service stations across the country and a commitment to innovation and reliability. In Farafenni, Jah Group is reshaping our industrial landscape. The Jah Oil Cement Factory can produce up to 100,000 bags a day, reducing imports, creating jobs, and building a stronger Gambia brick by brick. And in the heart of the Central River region, Jah Farming Initiative is cultivating food security. With thousands of hectares under development and modern irrigation, Jah Farming is turning the Gambia's soil into abundance. Jah Group is more than a company. It is a vision of self-sufficiency, resilience, and progress. The Jah Group of companies, investing in industry, agriculture, and energy, building the Gambia's future today.
Africa is rising and business knows no borders. With Bloombank and PAPS, buying and selling across Africa is now effortless. Fast, secure, direct from your Bloombank account. One Africa, one connection, one heartbeat of opportunity, powered by Bloombank Africa. Bloombank Africa, in partnership with PAPS, connecting Africa, empowering you. Bloombank Africa, we make it happen.
Dr. Fatoumatta Jarjusey is a Gambian trailblazer in medicine, recently becoming the country's first female graduate of the University of the Gambia to earn fellowship status in obstetrics and gynecology with the West African College of Surgeons. She's now a consultant obstetrician and gynecologist at Edward Francis Small Teaching Hospital, recognized for her pioneering role in women's health and medical specialization. And Dr. Jarjusey has chosen to start her week here with us on Coffee Time to answer questions and will make herself known more to all of us. Welcome to Coffee Time, Dr. Jarjusey, and congratulations.
Thank you so much, Uncle Peter. Thank you for having me.
Take us back to your early schooling. What shaped your decision to pursue medicine?
Thank you so much, sir. So from a village girl, I did my primary school in the village because I stayed with my grandmother. Then I came over to the Combos and went to...
Which of the many villages?
From Quinala.
Okay.
So Quinala is in Kiang Central,
Oh.
yes.
Okay.
Where my mom is from, and my grandmother brought me up. Then I did my junior school in Charles Jau Memorial Academy. We were the first batch of students. The school just started. And I went to...
A true pioneer.
Yes. Then I went to St. Joseph's High School, all girls school. Then from there I went to UTG in 2003 and completed medical school in 2010. Then UTG was just here. We had Dr. Bitey and Co as the first batch of
There
medical.
are two Biteys. There are two Dr. Biteys.
Mustafa Bitey, the
CMD.
yes, my boss and the CMD.
Uh-huh.
So they were the first batch to go to medical school in the Gambia. I think this was in 1999. So we also joined the medical school. I started in 2003 and completed in 2010. Did medical school and then started my house job. Did house job for 2 years. And interestingly, my last rotation was in pediatrics. That has to do with children. Dr. Bitey, actually, Mustafa Bitey is the one who dragged me to ONG, OBGYN, that's obstetrics and gynecology, to become a medical officer there. Then I took, after the houseman job, so that's for 2 years. You do your house job for 2 years, then you have to go on being a medical officer. Then I took some break. I went to UK to do a master's in public health and health promotion. Then I came back and then continued as a medical officer in OBGYN. At that time, we didn't have any residency program, so you are just a medical officer for as long as it takes. Thank you to Dr. Bitey, Dr. Keta. They came back from Ghana and then encouraged us to start this residency training, coupled with so many. It took the whole village for this residency program to start. Then residency, we started in 2018. So it took us about 3 to 4 years to become a specialist in obstetrics and gynecology. We went through so many training, so many exams, which most of them are not done in the Gambia. You either have to go to Nigeria or Ghana to do your exams. Then we did these exams in 2022 to become a specialist in obstetrics and gynecology. Then I wanted to further specialize and be a fellow or consultant in obstetrics and gynecology. But I've had passion for women's health. It's one of my passions I've ever had since I was a kid. So I went through the fellowship exams. This training took us another 3 to 4 years. Very intensive training on computer, and then so many, you need so many infrastructure, you need finances. Most of them were not done here. We had to go to Ghana, we had to go to Nigeria, and they have to bring some consultants here because sometimes it's cheaper for them to bring them than all of us traveling to Ghana or Nigeria. Then April last month, we did the fellowship exams, and alhamdulillah, we are here today as a consultant obstetrics and gynecology.
Fantastic. So you were leaning towards pediatrics.
Yes, I was.
What did Dr. Bitey see in you, the CMD today, to sway you to obstetrics and gynecology?
Yes, so he kept saying we need women in this field, we need to help our own women, and someone has to start. We can all be running away. It's demanding. Obstetrics and gynecology is demanding. You can imagine you are dealing with 2 lives, the mother, the baby, and the family. So it's so demanding. It's like we need our own women. They have to be comfortable. They have to be talking to their own women. This will help them. Our culture and society, sometimes we don't want men touching your woman or your wife. So it's like somebody has to start. And unfortunately, I had to be the guinea pig. And here we are, alhamdulillah.
Okay. Becoming the first UTG-trained fellow in obstetrics and gynecology is, of course, historic. How did you navigate the challenges of training, exams, and specialization?
It wasn't easy, sir. Alhamdulillah, we are here. It's, people didn't see what happened behind the closed doors. Like I said, it took the whole village. It's very demanding, being married, having a family, and then have to go long hours. Sometimes you are in the hospital for more than 24 hours.
Oh.
Mostly more than 24 hours. In the morning you wake up and the work has to continue. Patients, they don't understand that. Labor doesn't wait for that. The labor doesn't know whether you are tired or not. The baby must come if the baby wants to come. So it's very challenging, long hours, and the money is not much at the time. Probably they have to put more incentives and all. But then, yes, we are here. Yes.
And what does it mean to be a consultant? I think you call it OBGYN.
Yes.
A consultant OBGYN in Gambia today.
It's very demanding, but it's a good thing because now it means we have more areas to concentrate on, and two, also the patient waiting time will reduce. We can do most of our surgeries here. Patients don't have to travel to Senegal or even overseas to look for treatment. And also, it's very important because we are here to serve as mentors, as training. We are already lecturers. I'm a lecturer too in the University of the Gambia.
Okay.
And also involved in nursing school. They also invite us to give lectures. And also, we have a residency program that's 3 years, and then you have year 1, year 2, year 2, then you have to continue teaching. I mean, it's important because you also have to maintain the knowledge that you've gained before. So okay. Yes, it's demanding, but it's a good thing for the Gambia and the hospital because we are here. Probably more gaps will be filled, more surgeries will be done, and then patients going out will be reduced significantly, inshallah.
Okay, and in terms of the job itself, your daily experiences, what are some of the more pressing maternal health challenges that you face every day at Edward Francis Small Teaching Hospital? Yes,
so talking back around 5 years ago, we are more worried about postpartum hemorrhage, that is women bleeding in pregnancy after delivery. But right now, alhamdulillah, that's no more our problem. The main problem we are facing now is women having hypertension in pregnancy.
Oh.
So we cause it hypertensive disease in pregnancy.
So they were not hypertensive before pregnancy?
Before pregnancy. Most of them are not hypertensive in pregnancy, but they
become hypertensive once they
from
become
20 weeks of pregnancy. And you have some who had already been hypertensive, but again, this is being manifested more in pregnancy.
Is there an explanation for this?
Unfortunately, initially we had so many risk factors that were identified in the literature, like getting married early, changing partners, and being a hypertensive patient. But now these things are not even, are not the ones the patients are manifesting with. So we have so many patients presenting with hypertensive disease in pregnancy. So right now, it's our major problem in pregnancy. So we don't normally, now postpartum hemorrhage is the thing of the past. I'm not saying women are not having it, but now our main concern is hypertensive disease. Then you have so many other things, medical conditions, probably our lifestyle, our way of life. But yes, hypertensive disease in pregnancy, it's our main problem.
I understand you've done some research work on HPV,
yes,
which has drawn attention. What are some of the key findings of the research, and why are they important?
Yes, sir. So HPV is human papillomavirus. So this is the virus that is responsible for causing cervical cancer in women, which is a very concerning disease, and it's a public health concern. Unfortunately, it's something that you can screen for, and it can be treated if they come to the hospital early. So it's really sad. Women usually will present very late, and you can barely do anything about it. So I did the study as part of my dissertation, and human papillomavirus is still very common in the Gambia, and the prevalence was 10.4. And so you have a high risk type and a low risk type. The high risk types are the ones that will cause cervical cancer. And my study found out 52, which is a form of high risk type, was the most common prevalent in women presenting to the clinic. Which means we still have very high prevalence of human papillomavirus, and then that means cervical cancer, we still have a long way to go. So
how are we to tackle this? I'm sure you must have,
yes,
you identified the problem, you must have proposed solutions to the problem.
Yes, sir. So screening. It's very important, and it's very cheap. Even with the common vinegar that we used to cook with, you can use it to screen, and then this will tell you there's an infection going on. This can be treated, and then the woman will not develop cervical cancer. But again, public health awareness. I did, in my master's studies, I did just knowledge awareness of women, including even the health workers. Sadly, they don't usually come for their screenings, because most of them say they are not even aware. So we need to do more public health aware. So this is one of my priority areas now, to collaborate with radio stations like West Coast, GSM companies, so that we will encourage and educate the public on the importance of coming for their cervical cancer screening, because the vaccination is another important thing, but it's very expensive, and for now it's only usually they are given to school going girls, and most of them are donations. We cannot afford it, but screening and public health awareness, at least those things we can. But
and the woman can walk into any health facility and be screened.
Any health facilities. And currently, the human papillomavirus in the Gambia, EFSTH, we have the screening for the human papillomavirus. Okay. And you don't screen again until 5 years.
Oh, it's once every 5 years?
Yes, every 5 years.
Okay.
Others like the vinegar, we call it VIA, and then also pap smear is very common. You do it every 3 years. But for the HPV, you don't do screening until 5 years. That is a long time. And if you have the infection, at least it may take up to 10 years before it can actually manifest as cervical cancer. So that's why it's sad that women are coming in advanced state, because this is something you can detect early and it can be treated in the Gambia.
Okay. I was speaking to a politician last week on the program, and she flagged maternal mortality as still, a major concern. If it is still a major concern, what systemic gaps do you believe need urgent attention?
Yes, it is true. It's still a concern, but the data have shown it has significantly reduced. The last census, the maternal mortality rate was 289 per 100,000. We are talking about 400, 500 previous census. So it's coming down significantly. But yes, there's still room for improvement. One is our antenatal care. Gambia have a very good antenatal care, but we have to improve on the quality of antenatal care. Yes, we have many doctors coming up, but yes, still we have so many areas in the provinces, in the up-counties, that have to be manned by medical doctors. So they have in the antenatal care, but the quality have to be improved on. Like I was saying about the hypertensive disease, sometimes you will see the women will be seen, their blood pressures will be high, they will be circled. The health provider will know this blood pressure is high, but they might not know what next to do for the patient until they present very late. So our quality of antenatal care should be improved. Again, our men, you people have to help us. In Bundung, they have a very good system there. Men usually accompany their wives to antenatal care, and they've seen so much improvement, because you will be in that room, you will know what the woman will need, and then the support will be there, both financially and socially. So our men also have to help us in bringing our men. In Gambia, you have to depend on the man to say, yes, you have to do this, no, you have to do this till now. So if they are involved, this will also help. And then continuous training, and provision of infrastructure and also equipment. These are the things that will help for us to reduce more maternal mortality. But yes, we are getting there.
Okay.
Yes.
Well, congratulations. I hope you get there, sooner than you. Do we have a national strategy for women's health? And if we don't have, why should we prioritize one?
I stand to be corrected, but I don't think there is any for now. But it's very, very important for us to have it, because this will help us, the service providers, to know what to do and what not to do. And it will help us inform these women what can be done, what cannot be done, and the ways of. So I think if it is not available, like I said, I stand to be corrected. We need to have it. This will help us in a very good way.
Okay, all right. Doctor, who should start the process?
Yes.
The CMD?
Yes, CMD should start.
CMD should start the process.
He should start.
Assuming there is no national strategy.
Yes, assuming there is none, he should start, yes.
Now, how do you see the relationship between medical specialization and health policy?
Yes.
You're now a specialist.
Yes.
Does the national health policy, enable your work? Does it make it easy? Does it facilitate your work?
Yes, sir. It facilitates our work, because if there is a health policy, as things like national health insurance scheme and all those policies, this will help, because some of these women, they cannot even afford the quality of the antenatal care we are talking about. In government hospitals, it's really cheap, but then sometimes the materials are not available, and we have the manpower, but sometimes the facilities are not available, the medications are not available, so you need to go outside and get it. And some of them, they are like many of us average Gambians, and they may not be able. So if we have these national health policies and the insurance scheme, this will go a very long way in tackling the quality of antenatal care we are talking about. Because that's when we can tackle our maternal mortality. If the quality of antenatal care is there, we wouldn't be talking about so many complications that leads to these women dying.
Okay, all right. Now, as a woman breaking barriers in a male-dominated field, what message do you have for young Gambian girls aspiring to careers in medicine?
Yes, I wouldn't lie. It's not easy, and it has not been easy, but it's something that is doable, and I think I'm a testament to that. With determination, with focus, you can do it. You just have to prioritize what you want, and then just say, I would not say just some years of your life, maybe it took the entire time of my life, but you have to juggle with everything that is happening, and then you should be able to get there. It's very doable.
And would you say it's easier for them now, knowing that they have people like yourself already in there providing training?
Yes, actually, I will say that when we started, we didn't have this kind of mentorship. Like I said, it was Dr. Keita and Dr. Mustafa Abite that came back from Ghana, and we didn't have our first exams we had to go to Nigeria and did the exams, then come back here and wait for another 2-3 years to start the residency program. We about 6 of us, and then Kajali and other from other departments. So now they have that. You have a 3 years residency program. By the time you start residency, you have somebody from year 1, year 2, year 3, and so many consultants to help. We didn't have this. So yes, it should be easier, and we are here to help them through that.
Well, you're a lecturer. You lecture at the UTG.
Yes.
Do you see a lot of promise among, the female medical students you're lecturing?
Actually, I see, like currently in our 3rd year resident, we have 80% of them are women. Yes, so 80% of them are women. In coming few years, no, not few years, few months, we'll have 2 more consultants in obstetrics and gynecology, which are female as well. Okay. So yes, it's promising.
Okay. And in terms of doing the job, what innovations or alternative approaches, whether it's telemedicine, solar-powered clinics, could help bridge healthcare gaps in rural areas especially?
Yes, definitely. Telemedicine you mentioned is very important because these women can be sitting in their homes whilst we, the consultants or the health providers, can be talking to them and giving them what the quality of women living in the combos are having. Is very, very important. So yes, telemedicine is something that we can actually invest in, and they don't have to travel all the way from Bansang, from Basse to come to EFSTH to get their screening done or to get their other tests done. So yes, telemedicine is one thing. And also research, I think. There are so many gaps, there are so many questions that we need to answer, and this can only be done by research so that we know what our local problems are and the ways forward, how we can tackle them.
What are some of the biggest questions that still need to be answered?
The biggest
If you were to embark on a research, for instance, what 3 key questions would you want, the research to find answers to?
One is how to significantly reduce our maternal mortality and morbidity.
Okay,
that's one. 2, how do we increase our uptake of cervical cancer screening? Like I said, cervical cancer, women don't have to die from cervical cancer in 2026. So we need to find ways on how we can increase their uptake of coming for their cervical cancer screening. And also 3, the antenatal care. How do we improve the quality of antenatal care?
Do you care at all about men?
Uncle Peter, I did. That's why I say you people have to help us in our antenatal care, improving the quality of antenatal care. That's when we have Uncle Peter bringing auntie to the antenatal clinic. So it's very important. We need you people. I mean, you people are the heads of the family, and your words really matter. So we need you to come on board and support us so that we can get where we want to get. Okay. You people are important.
Back in the 80s, during the Jawara time, primary health care used to, be a dominant talking point. Mm-hmm. The way primary healthcare was being promoted. Mm-hmm. What's the place of primary healthcare today, and why is it not getting, the attention it got in the 80s, 90s?
Yeah, actually, they're still saying we have got the best primary healthcare in the sub-region. Oh. And yes, so we have so many. Now we have community medicine doctors that graduated, and they're supposed to be in the community, but I think we still did not get there. And we have midwives that can go to the houses, and our vaccination coverage also. These are all part of the primary health care. So I think we still, in the sub-region, we still have a very good primary health care. It needs to be strengthened, and it will help a lot. And also we have family medicine coming up. Recently they've graduated specialists, and this will also help it to fill the gap, because when you have family medicine, most of them will be dealing with the primary health care problems that will not get to the tertiary hospital. So yes, it needs to be strengthened, but it's a good one, I think.
Just maybe to emphasize the importance of primary health care, if we build on what we have already. I mean, you say we have the best primary healthcare system in the sub-region. But if we were to even further improve on it, would it answer some of the questions you have, for instance, relating to maternal mortality and cervical cancer?
Antenatal care. Yes, it will. It will definitely address most of the problems. So they wouldn't have to come to secondary healthcare or tertiary healthcare. So yes, it will address most
and
of
isn't it
issues.
cheaper to focus on primary healthcare?
Way cheaper. Like the saying, prevention is better than cure. And the primary healthcare will help with, the preventive measures. So
Dr. Bitey, put more attention on primary health care.
Yes, sir.
Looking ahead, what's your vision for women's health in the Gambia, say over the next 5 to 10 years?
Yes, sir. So my vision is to produce more consultants like myself and encourage women to go into sciences. And it doesn't have to be medicine. I mean, if you go into other STEMs, I think it will go a long way. But my priority now is more women coming into medicine. One of my colleagues said we don't want any man to be specialized in OBGYN. So which means we have to encourage more women to come over. So yes, hopefully in the next, like I said, in 6 months or 1 year, we should be having 2 more consultants, female. And then we have like the residents, third-year residents now, 80% of them are female. And so this will serve as an inspiration to younger generation. So we have more women, that our women will be comfortable. When you walk into the clinic, you will see faces of women, not men dealing with your problems. So yes.
Okay. All right. And again, just to, I know you touched on it at the beginning of this conversation, but for somebody just tuning in, I mean, you were an obstetrician and gynecologist for many, many years, but now you carry the additional title of consultant. What's the difference between just an obstetrician and gynecologist and a consultant obstetrician and gynecologist?
Yes, so when you are just an obstetrician, like a specialist, you are involved in your work, some training, and also mentorship. But being the consultant, the pressure is higher. Oh. So many expectations. So you are involved now, and also not just being a consultant, but also leadership and management, training and mentorship. So many responsibilities have been added to my work now. And so, yes, I'm still involved, fully involved in patient care, clinics, doing on-calls and all. The on-calls might not be hectic. The on-calls it's every doctor's nightmare. So being a consultant, at least is lessons. But in OBGYN, unfortunately, the more problematic the condition is, the more you require the consultants to set in. So the night hours will still continue, but yes, more responsibility.
Okay. And finally, on a personal note, what keeps you motivated in the face of challenges, and what legacy do you hope to leave?
Yes, Uncle Peter. So if I deliver a woman and then that smile on their face means everything to me.
They always do, I am told.
I forget about how many hours I worked for. Or you have an old woman escort that gives me $10 from her pocket. I mean, that woman, that $10, it means everything to her. It's better than you coming and giving me $5 million.
So you have an old woman,
yes,
escorting somebody to the hospital.
Yes.
You deliver them, they are happy, and they take out a $10 and say, doctor.
If you refuse that $10, they are like, Hannah, is the money small? Halis with the fund out, that's why you don't want to go. I say, no, grandma, no, you have to. So that smile on their face, it means everything to us. It keeps us motivating, and their prayers too. It's hard, but at the end of the day, you go home, and then you're like, okay, I've saved somebody's life. And then that's what keeps motivating us, sir. Yes.
You seem to be blessed with the ability to speak multiple local languages. You just spoke very good Wolof. I'm sure you speak good Fula.
Actually, I don't speak. My Wolof is not very good. I'm from Kaur, by the way. They have Salum, but because I was raised in Queen Alakiang, I speak more of Mandinka. Yeah. So Dr. Bite will be laughing at my Wolof. Yeah. It's not very good.
Just try to say something in Wolof and Mandinka about, these developments, in your sector.
No, okay.
Because very often when you talk about the health sector, you get very bad press.
Yes.
No, if you came home, Pagdi Bahut, so on and so forth.
Yes.
So, I mean, inform them in our languages about some of these developments.
So, Mbadi Mandinkolu, Binata Uncle Peter, West Coast Radio, so comme I fanya tubab kangoto ntemu musola Dr. Rolti and signing an consultancy bank, so bijande pour calma koy. Kujama beke kan health system yalan ko mul malong bijang pour musol la kono maya ela problem wol comme ni man dingol soto anim problem jama be so bijande pour calma koy lafta minna walem sanji kilinyato sangi sabanyato mol manya naka bojang kata bankoto bantala bankoto pour ka jara lo nyinigi so lafta wala mbijang Gambia jang saja ngal makoy al semistro Senegal anin tubabu du lafta ya so Gambia jang so wala sabu mbijang so onko pita suma olof bi setut bu baax so luma do wax ci sosé rek man Fatoumatta Jarjusey la tuda den consultant la obstetrics and gynecology which mean dama nekk fi pour dimbale jigéen yi pour ñu am doom pour ñu wasin ak any problem associated with that so our main luñ buga moy fi be ay ben at ñetti at ñenenti at ben Gambian jigéen du jéena fi dem Sénégal wala dem ci bitim réew pour ut fajum when it comes to women's health so loolu lañ fi negal and then we xam nañ ne su neexee yàlla we will get there.
yaaga nga liggéey ak jigéen yi yaaga nga dimbale jigéen yi ci seen wàllin jur ak yu ni demee waaye dafa am maxaama boo xam ne moom lañ la yokkal léegi ñu bëgg a nga wax ñu maxaama bu ees bii nga amee bi nga am léegi naka la gën a doolelee sa liggéey nga xam ne di nga gën a njëriñ jigéen ñi biir yi nga xam ne ñoom ñoo nekk ci réew mi
waaw soo lu mu gën a dooleel mooy léegi fu mu nekk nii nañ wax nañ ne léegi jigéen ñu bari su ñëwee lopitaan nañ am yenn surgery yoo xam ne nañ ko mën a def yokka si ñoo xam ne ñu fa already maa si ñoom docteur Bitey ñoom docteur Idoko ñoom docteur Keita ñun léegi yokk nañ si loolu noonu te man ma nekk jigéen loolu dafa gën a
bi ci kaw ñii la tegu
waaw ñooñu rek la tegu
yow léegi ñëw nga nag
waaw naa leen jàppale waaw soo ñu man tay boo lu ma daan def mooy damaa ñëw rek ma ne docteur Bitey am na patient boo war a opérer de ma toog na di ko xaar wala moo docteur Keita waaye léegi fu mu ne nii man ñeneen ñooy ñëw ñu ne ma docteur Jarjusey am na patient boo war a opérer de duma toog pour xaar docteur bi
su ko defee mu mel ni ki ñoom ñaar su fekkoon ne ñu ngi liggéey ci ñaari jigéen yow léegi mu bokka nga mu doon ñetta
waaw
keneen su ñuy yokk ci loolu
suñu doon opérer say 5 jigéen fu mu ne nii nañ mën a opérer ay 10 jigéen den pour jigéen yi tamit toog di xaar very long time pour ñu gis docteur oo ñu mën a opérer wala faj seen problème yi time bi dafa wàññeeku léegi so these are some of the things added advantage.
waaw yow nag docteur Bitey moom moo la ñaaxoon dugal la ci lii
moom la de
parce que yow bi nga jàng pour doon docteur da nga bëggoon a liggéey ak xale yi waaw léegi moom mu dugal la ci lii ndax yow it am na ñoo xam ne yaa ngi leen a ñaax pour ñu ñëw gën a jàppale ci lii parce que wax nga ne am na yenn feebari jigéen yoo xam ne ba tey mu ngi ñoo géteen ba si cervical cancer yi la wala sax su ñoo jéem a mucca
waaw definitely Uncle Peter maa ngi over sax si department bi am na so many people are looking up to me alhamdulillah and I hope I will be able to meet their expectations waaw so am na ñu bari xale jigéen yi muy ay xale góor yi sax ñu ngi ñëw bugg a nekk
waaw yow soo amee du la gënal benn góor du la du tegaat jigéen
waaw waaye den suma beneen boss na wane yéen ngeen xam ne da ngeen naa nekk maternity leave te soo ñëwee te suma doom bi moo feebar nga ñëw nga ne yaa ngi dem xew yaa ngi dem jënte yéen soo leen demee yan ñoo leen naa gis si jigéen yi biir yi waaye waaw am na ñoo xam ne ñu bari residency programme bi am nañ a good number ñoo xam ne ñu ngi ñëw man bu ma defee exams tamit am na ñetti xale yoo xam ne start nañ pour def seen residency bi ñoom ñëpp start nañ soo ñoom hopefully ay fii ba next mois ñoom tamit dañ start residency bi soo nombre yaa ngi yokku ni ñu bari ñu ngi ñëw and ñu leen naa mentor incha allah nañ fi nekkal pour dimbale leen and leen wan leen yoon bi
yow bi ngaa dugga ci lii daanaka gisuloo fa woon sa maas maanaam ñi fa nekkoon ñëpp ay góor lañ woon
waaw
mu métti woon ak yow be
torop sax
léegi nag yàlla def yow nga nekk fii foog nga ne bunta bi dina gën a yaatu pour xale yu jigéen yi
Uncle Peter waaw dina over yaatu sax pour xale yu jigéen yi comme ni nga ko waxee ñun bu ñoo dugga ay góor rek ñoo fa nekkoon so it was very difficult waaye fu mu ne nii ñun man benn consultant la am na yeneen consultant yu fa nekk di jox programme bi léegi right now ñu fa nekk yëpp wàllum 80% bi yëpp jigéen lañ so lii they will be inspiring others and then so that ñoom tamit dinañ ñëw so yoon bi dina ubbeeku insha allah ubbi na ba pare alhamdulillah
waaw wax ma diggante University of the Gambia fi nga jàngee ak West African College of Surgeons bi nga xam ne fa nga defee sa fellowship diggante bi ñaar ñi naka la ñoo liggéeyee
waaw so West African College of Surgeons ñoom ñoo nekk main body be responsible for all the way almost about 10 or 11 West African countries Gambia, Nigeria, Ghana, Liberia, Sierra Leone so ñoom ñoo nekk main body bi ñu dee organise exams ci training bi so ñoom dañ am fu ñëw University of the Gambia fu ñu ñëw sa lopitaan bi ñu seet ak sa hospital bi na mun nañoo train koo xam ne dina mun a standard comme kuy train Nigeria ak kuy train Ghana So initially buñ started ñoom dañoo nekk di seen fi seen nit ñi ñuy ñëw dimbale ñoom comme dama ko wee docteur Biteye ak docteur Keita ñoo start pour obstetrics and gynecology so dañ am pour seen nit ñi ñun tamit dañ daan dem foofu noonu Nigeria bu ko foo nga dem da nga am revision course yi nga war a def da nga am pour exams they has to be certified by the West African College of Surgeons so ñoom fa ñu ñëw wax la ne waa sa lopitaan bi mun naa train Fatoumatta mun naa train Kajaali pour mu nekk surgeon pour nga xam ne dina mun a train comme ku fi jógee nga dem Nigeria oo jógee fi dem Angleterre wala dem ñoom ñëpp dañoo am same quality so ñoom they are the bigger body ñoo xam ne they are responsible for accreditation for certifying and also supervising what is going on so they come saa bu nekk dañ dee ñëw seet lan moo nekk di xew ndax mit nga standard bi ndax sa néeg bi mel na ni ndax sa théâtre bi mel na ni so ñoom they are the bigger body responsible and UTG have been there to be able to provide that.
waaw léegi loolu yëpp dañoo fay ndax duñ fay te suñoo fay ñanaay fay loolu.
dañoo fay so it took the whole village for us to be here today. We want to start with Edward Francis balaa maa start suma waajur yi ñoom ma jàngal obviously ma nekk fi ba Edward Francis suma teaching hospital bi ko foofu leen di jàngee ñoom ñoo fa nekk di ñu dimbale then people like Dr. Mustapha Biteye Dr. Keita when they came back they met so we started this program and we had so many consultants, Dr. Idoko, Dr. Patrick, Dr. Egu, and all of them helped with this training program. And also we had so many help from the Cubans because most of our medical school we had when we started, it was just the Cubans that were here. So Nyam Tamit. And then China's Tamit. So come like we have something called minimal invasive surgery. Soon bagasi yep ñom China ñoo ñu ko démé and they are also then they am exchange program da nga dem 6 months ñom tamit ñoo for 6 months continuously which is ongoing. Then apart from EFSTH we also have the World Bank. The World Bank helped Ministry of Health. So the Ministry of Health has been the main sponsor for our program. They've been there. So we travel to Ghana or Nigeria maybe 5 times, 6 times, going for exams, and it's very expensive. So you have to go there. So the Ministry of Health, with their main partner, I think the World Bank, that helped. And then the government also have been very helpful. So it took the whole village for us to be here today.
I'm na leen loo xam ne dañ ko dee jógee docteur yi ñu ne docteur bu nekk am na private practice
waaw
dafa dem def liggéeyam nii jaar na léegi nguur gi jël alal gu takku googu noonu def ko ci docteur Fatoumatta Jarjusey xëy na mu ñu liggéey benn ñaar ñetti at rek dal di ne xaramaa ngaa dem private practice loolu moom seen ma use yéen seen laakaar loolu naka la fa taajoo
waa dëgg la kay dañ dee dem private practice because ñu ñoo fay waaye xaalis bi doyut so but the good thing is course it is more than private practice. Just know that after working hours la fa dee dem. EFSTH or anything anywhere is our main priority because foofu nga dee gën a mën a am patience foofu nga dee mën a am exposure then foofu nga mën a teach because it's the only teaching hospital so dañ dee dem private practice but most of them it's after working hours so suñ clinic starts at 4 p.m. or 5 p.m. suba bi yëpp dañ dee nekk Banjul so yes we doing private practice but our main concentration is Edward Francis Small and other allied hospitals.
xam naa ne parce que appointment bi yàgg nañ ko plan xam naa ne excuse nga sa boppa from maybe some surgeries ak whatever waaye xam nga mbir yi ku feebar rek xamuloo ban emergency moo fa toog di la xaar kon dañ la jaajëfal ne kontaan nañ ci sa teewaay bi just to round off everything any final message Dr. Jarjusey.
Thank you so much Uncle Peter. I just want to say I'm a big fan by the way but just the listening part not the talking part so yes.
Well, you've not joined the talking part. We'll be bringing you here more often.
Yes, so I'm happy to be here. Like I said initially, we are here to improve the maternal health service of the Gambia. That's why we are here, and we are hoping we will, the next time we are here, probably we're talking about maternal mortality being not less than 0, but, very drastically improve. And we hope to improve the quality of maternal and child health in the Gambia.
And to people who, whenever people come here and criticize the health system, and I tell them, just go to Edward Francis Small Teaching Hospital and look at the, impressive building. And they go, nice building, but people are still, lying three in a bed, they say. Yeah. 3 in a bed. Yes. 3, 4, premature babies in an incubator.
Yes.
People lying on the floor and all of that.
Yes, these are realities, but considering how many patients are there, you have only one teaching hospital in the Gambia. And every health center, every country is fighting to this. We don't have the capacity to maintain all these patients. Yes, they are working on expansion. Yes, there are so many works ongoing, but the public just have to bear with us. And in as much as patients are here in Tribe, we try to, as much as possible, to give them the quality of care that they deserve. Yes, we will get there. And I'm so, yes, Dr. Bitey and the minister are probably listening, or they will listen, but they are doing a very good job. And the public just has to bear. Just not, you have 3 patients on a bed, but we give them the best quality
Rome was
of care.
not built in a day.
Yes,
Okay.
exactly.
You make the point that we have only one teaching hospital. Can we have more? And if yes, why are we not having more?
Yes, we can.
Can we
have
upgrade
more.
Canifing General Hospital, for instance,
yes,
to a
yes,
teaching hospital?
yes, definitely we can. And so with this postgraduate and residency program, and having more consultants on the ground, we should be able to upgrade places like Canifing, even Bansang, to a teaching hospital, and this will actually improve the quality of service and also reduce the workload and also social media attack on AFS stage and Dr. Bite. So yes, hopefully with this training and also the postgraduate, more consultants coming up, we should be able to have, because you need to have specific number of consultants in one place for you to be for a teaching hospital.
About how many? 7?
Maybe, yeah, so I can't remember the figure, but for each trainer, let's say, about maybe if we have 3 residents, you need to have at least 1 consultant to be able to train those people.
Okay, so there's the 3 of you. You named Keita and
Yes.
Bitey
Yes,
before, so
yes.
that's 5 at least.
Yes, we have at least 5 years, but we
Okay.
have almost 20 residents or more than that in training in the FSTH. And we have to go outside. So just not EFS, you have to go outside to do your rural posting. I did mine in Brikama. So it means when I'm there for that 3 months, a consultant has to be attached to me.
Okay.
So which means you have only 4 in Banjul. And then we still have to refer them. So we will get there. Like you said, Rome was not built in one day. So, but we will get there. Canifing, yes, can be a teaching hospital. And this will help.
Congratulations once
Thank
again.
you so much, Uncle Peter.
Dr. Fatoumatta Jarjusey, thanks for being here this morning. And she's a consultant obstetrician and gynecologist whose pioneering journey has broken barriers, hopefully inspired a new generation of Gambian doctors.
A better way to pay your UTG fees with instant proof of payment and real-time student portal update. Paying your University of the Gambia fees has never been easier or more convenient. With Ecobank, students, parents and guardians can pay UTG tuition and related fees through our secure digital banking channels such as Ecobank mobile app, Ecobank Online and Ecobank Omni Lite. Once payment is completed, instant proof of payment is generated and the UTG student portal is updated in real time, allowing students to proceed immediately with registration, course selection, and clearance without unnecessary delays, while giving parents and guardians peace of mind that payments have been successfully processed. How to pay via the Ecobank mobile app. Open the Ecobank mobile app and navigate to the home screen. Select Pay Bill, choose Pay a New Bill and select Schools from the category options. Select University of the Gambia. Select the specific product you are paying for. Enter your matriculation number and tap Continue. Validate your details. The system will display the payable amount. Press Continue to confirm the payment. An e-receipt is generated automatically as proof of payment with real-time updates on the student portal. How to pay via Ecobank Online or Omni Lite. Log in to Ecobank Online and Omni Lite using your credentials. Select the menu and choose Bill Payments. Choose Quick Bill Pay and select School from the category options. Select University of the Gambia. Select the specific product you are paying for. Enter your matriculation number and tap Continue. Validate your details. The system will display the payable amount. Press Continue to confirm the payment. An e-receipt is generated automatically as proof of payment with real-time updates on the student portal. Walk into any Ecobank branch or pay through our digital channels and enjoy instant proof of payment with real-time updates on the student portal. Ecobank, the Pan-African Bank.
Vif lay fay. Sant yàlla.
looy xaar utal Wave nga scan nga fay te nag doo ci yokku dara.
Scan to pay more, no problem.
Jah Oil Company stands tall as a trusted name in energy, keeping the Gambia moving with service stations across the country and a commitment to innovation and reliability. In Farafenni, Jah Group is reshaping our industrial landscape. The Jah Oil Cement Factory can produce up to 100,000 bags a day, reducing imports, creating jobs, and building a stronger Gambia brick by brick. And in the heart of the Central River region, Jah Farming Initiative is cultivating food security. With thousands of hectares under development and modern irrigation, Jah Farming is turning the Gambia's soil into abundance. Jah Group is more than a company. It is a vision of self-sufficiency, resilience, and progress. The Jah Group of companies, investing in industry, agriculture, and energy, building the Gambia's future today.
Africa is rising and business knows no borders. With Bloombank and PAPS, buying and selling across Africa is now effortless. Fast, secure, direct from your Bloombank account. One Africa, one connection, one heartbeat of opportunity, powered by Bloombank Africa. Bloombank Africa, in partnership with PAPS, connecting Africa, empowering you. Bloombank Africa, we make it happen.